They won't do I think they will put the presentation yet.
Yeah. So thank you for coming in this very intimistic session. I'm Maki. I'm leading the unit of international neuroradiology in Geneva, and I came with the head of the neurology of the anesthetics department for not operating room in Geneva, Dr. Chenesky, and we will share with you our way to manage a stroke patient, and especially a patient presenting an acute ischemic stroke secondary to large vessel occlusion. What is interesting to me is, and which my topics is, to share with you our algorithms. This is a slide in which I will just give you an idea of our catchment area. In the red round, you have hospitals, which are peripheral hospitals, sending us patients. We receive a patient from certain peripheral hospital in Switzerland and in the France. France is just out of the border. The border is 7 kilometers from Geneva. And this is the population of patients that we treat. Actually, the only subgroup of patients that we don't treat is the patient without any proximal occlusion. Then, if patient presents a large vessel occlusion, we offer IV lysis if you are in between before 4.5 hours, and then we go for thrombectomy. Indication for endovascular thrombectomy at our center of the presence of proximal occlusion. In this line you see an asterisk because proximal occlusion is the title of this topic, but in reality we still treat distal occlusion when they are related to poor symptoms like aphasia or plagia. We consider also thrombectomy for distal occlusions. We select patient by CT perfusion, and one of the main factor that to look what is the CBV, the cerebral blood volume, which has to be the extent of the core has to be less than 70 milliliters, and for sure we would like to treat patient with a clinical radiological mismatch. Then we have no limits for the age of the patient. We have no limits for the time, meaning that because we select with CT perfusion, and because the very, very famous trial that were published recently, Dawn and Diffuse 3, we don't have limits in terms of time if patient was selected with CT perfusion, and CT perfusion say to us that we still have a penumbra zone to save even beyond 6 hours from stroke onset. The same for age. Usually we look at the biological age of patient. So if patient is 90 years old but was playing golf just the day before the stroke, we go for the treatment. And the same if patient was not so brilliant in terms of health but was having a normal life even for his age, we go still for treatment. We don't treat when the occlusion is distal, so when we have M2, M3 occlusion in non-dominant hemisphere, for example in the right side, and when the occlusion is related to a core which is already present, and we have, in other words, nothing to say, we don't have any penumbra. In that case it's very easy. We don't go because we think that the balancing in between risk and benefit of the treatment are more prone to risks, so we don't offer thrombectomy, mechanical thrombectomy. The other point is that we know, or we have a high suspicion of underlying stenosis in the cerebral artery, which is the the place of the occlusion. We don't like to perform thrombectomy with either stent retrievers or aspiration catheter against stenosis, because the risk that we take is that we have a damage of the vessel without even a worse situation and permanent occlusion without any possibility of recanalization. And very often those patients are particular subgroups with low NIH score, with low clinical symptoms, and they don't really need mechanical thrombectomy. If we don't know that there is an underlying stenosis, as very often happens in the real life, because it's not so easy to understand or to do to make a diagnostic of stenosis. So in that case, we still go and offer thrombectomy. But once we realize that there is an underlying stenosis, in that case we switch technique and we think we consider to perform angioplasty and eventually stent, but with the non-stent retriever with the normal stent. Then we have a big discussion with our neurologists every day about a patient with a ranking score or less than or either than 2, meaning people who has not dependent patient. So the idea is, the question is, we have to treat or not that patient, because we very often don't know, and we have a very short time to make a decision. We preferentially go still for treatment for those patients. The same thing for patient with short life expectancy, for example for a cancer patient. Again, we don't want to take decision against the patient. We don't want to make a decision in a very short time period. Very often we don't have the all information of the patient and especially life expectancy, response to therapies, cancer therapy, etc. So we prefer to still treat those type of patient. Another interesting topic is how to select patients which are sent from peripheral hospital. Every day we receive patients from 7 other hospitals, so we had to establish a pattern for the workflow of the patient. The pattern was relatively easy established. Neurologists of peripheral hospital get in contact with the neurologist in our hospital to discuss to propose the patient for thrombectomy. At the same time, they have to send imaging, meaning using email or WhatsApp or whatever to send us imaging. We don't have access to other hospital packs or imaging, so we need to find out any means to get those imaging. And of course, again, with along with clinical information about the patient, we make a decision and we accept this patient. The patient is transferred to our hospital. Then when the patient is at the entrance of the hospital, the resident neurologist assess again the clinical status of the patient using the NIH score. If NIH score is exactly the same, we retain that the penumbra is exactly the same that we had seen in the previous imaging performed in the peripheral hospital. So we don't want to waste time and we go straight forward for thrombectomy in the angiosuite. This pattern is very short, it's very rapid, and we have timing of between 4 and 14 minutes to get the patient from the entrance of our hospital to the angiosuite. Of course, this is for patients with no changement in their clinical status. Then we have changement or patient with changement. We are getting better or getting worse. In that case, we have to look at how the NIH score changed. And for scores higher than 4 points, in that case we suspect an hemorrhagic transformation. Very often those patients receive a TPA at the peripheral hospital, so we go for CT scan, repeated CT scan. The same if we have improvement with dramatic improvement. In that case, we don't want to go to the angio suite because very probably the artery was reopened by the lysis, and we go again to the CT and CT angio. We also had cases which are not clear, the CT perfusion, and we use automated software. When you receive patient from a peripheral hospital and the best have the condition, you get all information, clinical information, you get good imaging, and you are able to make a clear decision. This is not so frequent. It's when patient has a proximal occlusion, has a low NIH score, and a clear imaging, either MR or CT scan showing very little ischemic core. So in that case, we are very happy, and even 3 hours after accepting the patient, if the clinical situation didn't change, we go to the angio suite. But it's not so frequent. Very often the imaging are not received in time. Imaging in the peripheral hospital are not clear. Clinical situation is not clear as well because patient had a strange NIH or too much high NIH at the peripheral hospital. So you want to repeat imaging. In that case, for sure, you from one hand you waste time because you already had an imaging, but on the other hand, you don't take the risk of offer to the patient a fetal thrombectomy. So for sure, this is not something that, well, it's perfect. I think that nowhere perfection does exist. So it's something that we have to improve, and every week we work to improve it. We have from last year dedicated vascular neurologist at the emergency department. They do the RTPA injection straightforward in the CT room just after acquisition of the basal CT without waiting for CT angio. CT angio is performed just after the injection of RTPA. Then we have automated software for patient selection. Automated software, it's not the only tool we use, but it's just one another tool, meaning that we have different arms against stroke, and automated software are very helpful, and they are an additional arm against stroke, an additional tool to select patient. We will see it's very useful, especially in the night time when we are on call and we receive an email in our email account. It's very clear what we have to do. It's now 3 years that we use this software, so we are confident with that, and we are very happy because it's straightforward and help us a lot. Then we transfer patient directly to the angio suite when accepted from peripheral hospital, which is a new point that was clarified 1 year ago. And very important, and I suggest you everybody in the meeting to try to reproduce it, is a weekly staff with neurologists or with all people involved in stroke treatment. We review actually all cases treated during the week, all interesting cases, all problematic cases, complication cases, not just from a technical point of view, but also for management, for delays. Highlight this staff. I have reports of all patients treated. I show to neurologists what we have done in the angio suite, how the procedure was, and at the same time we analyze all the delay in terms of patient admission, patient transfer to the CT room, patient transfer to the angio suite, etc., etc. And every time we take the opportunity of improve the system based on what we have done. And this is something that we do every week. It's a very important tool who get union in between different teams treating stroke. The same is the formation for technicians. Technicians in the angio suite are our allies. It's something that we have to think too, because without nurses or technicians which are involved in this treatment, we cannot perform it. We need the have to be motivated because they help us during the night when we are alone in complicated situations. It's very, very important to have beside you somebody who is motivated to help you. That's why we do workshop for them, we do simulation for them, and they are sent regularly to meetings, stroke meeting, ischemic stroke meeting, hemorrhagic stroke meeting, etc. And then we have again with them a meeting every week. Every week we discuss with technicians, with nurses, because they have to be aware of why we have chosen that catheter or that stent, and then we changed our mind and we took another one, etc., etc. You are not able to explain to them during the case because you have to be concentrated and focused on that. But afterwards, in a very calm situation, in a conference room, you can explain what you have done and why, and they appreciated that because they start to understand they are not there just to open boxes. And you spend time which is precious for you for sure, but then you recover those time in the angio suite, and it's very, very important. Then we have done some modification in the angio suite as well. In terms of ergonomics, we have tables with the measure of catheters. We prepare everything before patient being intubating. We intubate all patients, we'll see later on. And also we have closet with the wells, because we put all stroke thrombectomy materials in that closet, and technicians knows that they just have to take this closet. Even we work into different angio suite which are far away one from the other, so when we move to the other angio suite they are prepared and easily can go to that. A big issue is how to select MR CT scan. It's not so problematic issue. I think that it depends about different things, facility, habits, capability, etc. By the way, both techniques are useful and effective in selection, patient selection. For sure, MR maybe is more precise for specific subgroup of patients, especially for wake-up stroke or for posterior fossa stroke, but they are just a little percentage of stroke patients that we treat. Then a CT scan could be very effective. If you use MR, what sequence we use? It's a DWI, flare to do a gradient and TUF. It could take between 15 and 45 minutes, it depends where you do. If you do in our hospital, we have 8 MRI, and we spend 1 hour to perform an MRI for a stroke patient. But if you select by CT, we spend just 15 minutes. Why? Because we have habit with this. I've been working in France for 10 years, and they select patient with MR. If one day, because MR is not working, they select for CT, and for CT angio, they spend 1 hour to perform the CT angio, CT perfusion. When we do CT scan, which sequence we consider, of course, is pre-contrast scan, then a CT angio, and then a CT angio perfusion eventually. And then we use to measure the extent of the ischemic core using the CBV or CBF and automated software. A very short clinical case was a patient treated in France a few years ago with an NIMH score of 15, presented with left hemiplegia in the morning with different risk factors for stroke, and this was the MR performed at the entrance of the patient. As you can see, the MR for sure is very precise and evaluate the extent of the ischemic core, but because probably different age of the lesion, it's not so easy to evaluate the extension. For sure, patient has an NH score of 15, it's still a young patient, 68 years old for us is still a young patient, so we prefer to go for thrombectomy. By the way, we had some concern to select this patient on this MR because it's not so straightforward to understand the extension of the ischemic core. But then, other than this, it was a tandem occlusion. But if you look at this on your left side you have the extent of the ischemic core, and on the right side you have the penumbra. So now it's much easier to make a decision because you have 17 milliliters, which is very low for an ischemic core, and a huge penumbra zone, which is even 7 times, well, 8 times, higher than the penumbra. So it's very easy to make this decision. So we pass through the proximal occlusion with an intermediate catheter, and we recanalize the intracranial, and then to get the opening of the carotid, we did angioplasty with complete reperfusion of the intracranial level. This is the control made after the treatment, with essentially the same extent of the ischemic core, and then we finally treat by stenting the carotid of the patient 2 weeks later. So this is famous Revit software. I say the famous because it's the software used for 2 of the 5 trials demonstrated the benefit of the mechanical thrombectomy, and recently by the other 2 trials demonstrating the benefit of the thrombectomy up to 24 hours after stroke onset. This is just to give you an overview of, this is my laptop screenshot, just to give you an idea of how I receive the imaging on my email account. And when I'm at home sleeping or reading newspaper, then I get this within my emails, and I look at this immediately, and immediately I know what I have to do, and that I have something to treat, and the decision-making process is very short and fast. Again, some imaging about this we can receive in our mobile, and eventually we can also get the spec score, but I don't have this application. And this is the present at our center. Then there's a big issue about general anesthesia, constant sedation. It's not at all an issue for me. I treat 100% of patients on general anesthesia, but it's not so easy to discuss in a few minutes. It's a big chapter of this topic, and I leave my colleague Dr. Chenesky, which is the anesthesiologist with which I have the honor to work every day to describe our workflow for anesthesia. Thank you very much.